Welcome. Thank you everyone for joining us for the Maryland HFMA payer panel discussion, how payers and providers have partnered to serve their communities throughout the COVID-19 pandemic, a spotlight on telehealth. We're so glad you could join us. This afternoon, we at the Maryland chapter of HFMA are grateful that we can continue to offer education sessions throughout this time, even though we're sad that we can't be all together in person, but thanks to technology, we can continue to host these great events. My name is Gabriella Gold. I'm one of the directors with the Maryland chapter of HFMA. And on behalf of HFMA, I want to thank our sponsors. They're listed on the screen, and also our panelists who have joined us this afternoon to participate. A couple of housekeeping items before we get started. We will have two polls that check for attendance. If you are using this session for CPE credits, we'll need you to go ahead and respond to those two polls so we can make sure you are actively participating the whole time. There's going to be one at the beginning and one at the end, and my fabulous host, Kalita, will be launching those polls as soon as we get started. There's also going to be a third poll in the beginning, and this is just to help our panelists get to know who's in our audience a little bit better. So please answer when those polls come up on the screen. So I think with that, we can go ahead and get started. We have a fabulous group of panelists today. I'm really excited. I can tell you when we had our prep call for this event, I was having so much fun, I didn't want it to end. It's really been great discussing lots of interesting topics with these professionals in our field. So with that, Kalita, I'll let you go ahead and launch the first poll.
First poll question is, what type of organization do you work for? The second poll question is, what is the top priority, RA COVID, for your organization? We will give you another 30 seconds to respond. Thank you.
Awesome. And once we have those results, Kalita, if we can also share them on the screen, that would be great. Okay. So it looks like we're mostly from hospitals and health systems. And our top priority is ensuring patients still have access to care. Great. All right. Thank you, Kalita. Do we do the other poll now, or do we do that one a little bit later?
We can do it now since we're in the mood.
Fabulous. All right, one more poll. If everybody could go ahead and confirm their attendance.
We'll close the poll in 15 seconds.
Okay. I like that 7% of our attendees are not present. That's great. Wonderful. All right. At this time, we're going to go ahead and let our panelists introduce themselves. I will ask that you all go on the order that your name appears on the screen.
Yeah, good afternoon, everyone. I'm Emily Yoder. I am an analyst at the Centers for Medicare. I've been with the agency for around 6 years, and I've been that entire time working on physician payment policy. I've been sort of the lead analyst for telehealth and other virtual services for the past 5 years, and I've been very involved with the expansion of sort of payment for Medicare telehealth services in response to the PHE, particularly the waivers and the 2 interim final rules.
Thanks, everybody. This is Bill Sheehan with MedStar Health. I'm a system vice president at MedStar Health and deputy director of our Innovation Institute. I have executive responsibility over learning infrastructure and telehealth at MedStar.
Hi, I'm Gene Ransom. I'm the CEO of MedCai, which is the Maryland State Medical Society. As I'm sure you all know, MedCai is the 7th oldest medical society in the United States, and we represent Maryland physicians.
Thank you. All right, I'm going to stop sharing my screen so that hopefully you all can see our wonderful panelists in full panel view. Throughout the session, if you have any questions, please go ahead and use the Q&A function at the bottom of the toolbar and type in your questions. If they're relevant to something that we're discussing at the time, I'll try and review it and ask the panelists and prompt them as they come in. So we'd like this to be as interactive as possible. We've got lots of great questions prepared, but we'd love to hear from the audience and have you all participate as we go along. We'll also try and reserve some time at the very end. If there are any unrelated questions, we can capture them in the last 10 minutes or so. So with that, I'll start with our first question, which is, how does your organization define telehealth? So there are lots of definitions floating around out there regarding telehealth. Is it audio only? Is it audio and video? And what's the difference between telehealth, telemedicine, and virtual care? I'll let Bill go ahead and start.
Thanks. Yeah, we at MedStar use a pretty broad definition of telehealth, and it's inclusive of typical things like video visits, both synchronous, scheduled video visits, as well as synchronous unscheduled, so urgent care on demand. As well as text interactions, chatbot interactions on the digital side of that, and then also remote patient monitoring on the kind of continuous touch point engagement with patients perspective. So we use a pretty broad kind of conceptualization that's both synchronous and asynchronous, and a number of methodologies in doing that.
So I can speak to sort of the opposite end of what Bill just described, which is the definition of telehealth under the Medicare statute. So the Social Security Act is very specific as to how CMS can pay for services that would have otherwise been performed in person, but are furnished through telecommunications technology. So the statute specifies that the beneficiary must be in a rural area. They have to be in a healthcare facility, so not in their home. And there's a certain sort of list of practitioners in the statute who are eligible to provide these virtual services. And the communication technology must be two-way audio, video, telecommunications technology. And so when all of those conditions are met, Medicare reimburses the same as if the service had occurred in person. So that is sort of a very kind of, it's more sort of the circumstances under which Medicare will pay for these types of services rather than sort of a description of the services themselves. As I said, the services themselves are services that would have otherwise occurred in person. So CMS also pays for, but we do not consider this telehealth. We pay for certain types of virtual services. They just, again, they're not considered telehealth and they're not subject to all of the restrictions in the statute. Things like remote patient monitoring or sort of short communication technology-based services that are meant to sort of prevent an in-person service. Also, things like remote evaluation of a diagnostic images, and certain care management services can also incorporate telecommunications technology. So we still pay for many of the same things that Bill was describing, but the actual definition of telehealth specifically is very narrow.
And the only thing I would add in our definition is probably more aligned with Bill's from the physician perspective. The only thing I would add is that I think when we're dealing with physicians, when I'm talking to one of my members, That's a baseline question you have to ask, because one doctor might think that it's phone calls, another doctor might think that it's a telehealth visit that's billable under the pandemic, and another doctor who's more sophisticated might think that it's full remote monitoring and the CMS codes that started getting paid in January of this year. So that's an important baseline question when you're having this discussion.
So a little foreshadowing, because the next question is in regards to our experience with COVID-19. What is one innovation that you all have really seen take off? We've obviously alluded to telehealth being one of them, but can you talk a little bit more about specifics around an innovation either within telehealth or something that's related that you've really seen be successful during this time?
Yeah, I don't mind starting on this one. And I think the first one we do have to start with is telehealth. I think the payers relaxing things so it can be used has been an incredible success story. And what's going to happen is when we get through this pandemic, we're going to have to figure out how we adjust to a new normal where patients are going to expect telehealth as part of the way they receive services. And it works very well. I'd say the other thing, and we did mention this, is remote monitoring. When the rules changed back in January pre-COVID, I did not have physicians asking me about remote monitoring. It was an afterthought. I now am regularly getting phone calls from doctors in all types of settings, both as employees in larger institutions saying, we're thinking about doing this. Are there any legal concerns, and who pays and who doesn't? To independent practitioners who are going, you know, I'm not seeing some of my patients as often and I'm worried about them. Can I do remote monitoring so we can keep track of them and make sure that they're going to be okay because they're not coming in the office on a regular basis and they have a chronic condition? So I think the remote monitoring really, the whole evolution of that got accelerated as a result of the pandemic.
Yeah, I would add to that. That's a great description by Gene. I would add that, you know, really we've kind of completed a almost proof of concept of a new care delivery model that includes a lot more kind of digital touches during COVID. And that includes for us everything from, again, chatbot technologies and kind of lightweight ways to interact with or engage patients, you know, around text messaging, et cetera, all the way to, you know, kind of synchronous video visits and remote monitoring as Gene described. And at MedStar, many health systems and hospitals face the same thing. We were quickly faced in March with, you know, kind of the declining ambulatory volumes, the increased severity being seen in patients with COVID coming into our hospitals, you know, requiring something we haven't talked about yet, which is distributing expertise like critical care medicine, palliative care, ethics across all of our hospitals, even though those are typically things that are kind of concentrated in our academic medical centers. And so, you know, we were quickly faced with all of that, and we kind of leaped across, you know, with, as Gene described, many relaxations at the federal level and at the state and payer level related to kind of telehealth reimbursement and things like licensure and all of these barriers that existed pre-COVID. We leaped across all of those and quickly moved a significant part of our care model virtual. In the case of MedStar with our ambulatory volume, I mean, 50% of our volume moved virtual in the course of a week. You know, pretty incredible. And actually, as of this week, since March 23rd, we've done 300,000 scheduled virtual video visits. You know, pretty incredible volumes. We've done 32,000 urgent care on demand video visits with patients. And more than 40,000 provider-to-provider consults across our system. So, you know, extraordinary volumes. It made us learn fast how to do this. And as Gene described, now we're in a position where we have provider and patient kind of openness to telehealth as a new part of the care delivery model. And so it allows providers and patients to consider new things like remote monitoring as a way to kind of extend care interactions and transactions into the home, with engagement, physiologic monitoring, those types of things to kind of fill the white space between traditional transactions of care.
Yeah, I mean, the only thing, so sort of from Medicare's perspective, I think sort of broadly, I cannot agree more with what Bill and Gene have said. I mean, we have been sort of confronted with the fact that delivery, like care, models of care have changed in response to the pandemic. And I think it has really illustrated how sort of Medicare's approach to payment for virtual services is sort of, has kind of in many respects sort of lagged behind the times. And I think that, I mean, what we've learned is, I mean, the administrator says it, I think the term she uses is the genie is out of the bottle. And so I think it's just really illustrated that we have to sort of think very hard about what flexibilities we need to maintain on a long-term, on a permanent basis. The only other thing that I would add, just from my own personal experience with this, is the thing that was sort of most, not surprising, but I thought sort of interesting about the Medicare population specifically, was the importance of audio only availability of care. I think that, so while we put out our physician fee schedule proposed rule last week, and while we're not proposing to sort of keep the audio only flexibilities for many of the sort of behavioral health and counseling services, but also the audio only assessment and management services, we are definitely aware of the importance of sort of the availability of that particular communication modality.
Fascinating. I think we're so fortunate to have representation from our health system community, our provider community, and our payer community all on the same panel. So I want to talk about, how has your interaction with each other changed as a result of COVID-19, or how are you changing the way you're communicating within your own systems? So as we develop these new care models, what are the new focal points of discussion?
You want me to go first?
Sure.
Okay. So I would say, so MedChi, obviously, we spend a good hunk of our energy advocating for physicians, and at times that can put us at tension with the payer community. I will say that I think that a positive out of this is we have developed a more collaborative relationship with the payer community during this period to try to work through the problem. Particularly, I have to give CareFirst credit. They came up with funds to help set up telehealth grants for small practices that MedChi administered in partnership with CareFirst. We have helped over 250 between the Maryland Healthcare Commission grants and the CareFirst grants practices implement telehealth during the pandemic. I mean, that's huge. We're talking about large numbers of physicians who helped have access to the technology, and that's a sign of partnership. I'd also have to give credit to the state. I think on the physician side, the state did a very good job. Secretary Neal made a decision to put Howard Haft in charge, and we were doing regular update phone calls with him, getting updates from the state from one person. Right now, we used to do them all 5 days a week. We're down to 1 day a week. They're open if anybody wants to come on. We actually, MedChi is providing at no charge CME for anybody who wants to be on there, and they get good updates. I have to give CMS credit. A lot of my members, and I've been on a lot of the calls they've been doing, you have a series of different calls you're doing depending on, so like, for example, I think tomorrow or today is the nursing home call, and anyway, but there's different check-ins with CMS, and they've done a very good job. And I would say too, that the hospitals, the systems, have treated the doctors who are my members who are employed rather fairly, generally. There has been some issues with some of the aggregators, I'd say. I've helped some employed physicians in aggregator situations where they feel they maybe weren't treated as fairly. But as a general rule, the hospitals treated their employed physicians very fairly. I'd have some questions or comments about contracts or other issues. So I have to say that generally, I would argue that at times, while there might be tension between the physician community and the payers and the hospitals, and sometimes we're friends and sometimes we aren't, and sometimes we're frenemies, I think this crisis has kind of brought us together a little bit, and we've worked well together. And I'd be remiss if I didn't mention Kaiser Permanente, who literally didn't lay off a single employee and kept paying everybody full freight. I mean, there were a lot more examples of positives like the Kaiser example than there were negatives. So I think we've shown as an industry that we can come together when there's a bigger purpose and a goal. And hopefully we can build on some of these partnerships and bridges that have been built during this crisis after it's over to make for a better general system.
Yeah, I think definitely from the perspective of sort of CMS, we've really tried to be as accessible as possible. Generally speaking, sort of there's various sort of set ways in which people can interact with the agency, sort of like notice and comment rulemaking, or sort of coming in and seeing us in person. And, you know, we do various types of outreach calls and whatever, and we've really tried to sort of take those avenues and expand them as much as possible. So, you know, interim final rulemaking and sort of the now the PFS proposed rule, which is open for comment, and sort of all of the calls that Jean was mentioning, and the various outreach sessions and the office hours, and just really trying to be as sort of interactive and collaborative. I really like that. I really like that phrase, because it has felt like at points in time very much more like a collaboration than sort of a set of top-down kind of like regulations.
Yeah, I would add to that, or maybe supplement it by saying it's really been collegial, and I think at all levels it's been extraordinary to kind of watch that collaboration, as Emily described it, to solve what have been actually really difficult problems. And I think there was an opportunity that if we weren't collegial, to do the wrong thing for patients in COVID and to actually cause harm. And there, honestly, from my perspective, has been almost none of that. It's really been barrier lowering. It's been collegial in approach. And it's not that it's wanton, right? Because I think that this has come with good accountability and good discussion of appropriateness of utilization. Because the truth is, telehealth is not appropriate for everything that needs to be done in medicine, and that there does have to be a continuum of care that includes digital and in-person and tertiary and quaternary care downstream, and that really the interest of all of us is in finding the right balance amongst those. And I think that we personally, me personally, and MedStar as a whole, we've had really great conversations about what does that long term look like, right? What is the right kind of balance of in-person and virtual care, technology-based care moving forward? And while I don't think anybody has the answers, I'm really excited about the dialogue that's happening right now, both nationally and locally, related to that balance of care across telehealth and in person. And lastly, I guess I would say that the idea of, is telehealth really something that is going to add visits that were not previously there, is a really important question that has been asked for years in the federal government. Is this really going to blow up the CMS cost structure? And what's interesting, I think, as we watch the recovery from COVID, we're actually starting to get some really good data that says no. It's a wonderful supplement to in-person care, and replaces those visits with virtual care where appropriate. And if we can find, in our opinion at MedStar, is every service line is probably different. Every specialty is probably different in terms of what's the balance. Whereas a dermatologist, other than procedures, may be able to do a lot of their work virtually via telehealth, and somebody who is a surgical specialty may only be able to do post-operative visits that way. But we have to kind of do that work together with our payer partners and physician groups to understand how to do that well.
Bill, I want to stick with you for a minute. You gave some really amazing statistics earlier about the number of telehealth visits that your organization, MedStar, has been performing. And then you spoke about kind of the new clinical care models that are emerging. What are the infrastructure consequences of that, positive and negative? And then maybe Jean and Emily, from MedCai and CMS's perspective, what can your organizations do to support this new infrastructure?
It's a really great question. And honestly, it's been a struggle, and we leapt over many of the problems during COVID just to solve problems. And now we're having to kind of look backwards and say, oh, we really do need to consider how this, how this is going to impact our overall model of care. And obviously, when you move 50% of your care virtual, there's infrastructure, practice infrastructure, real estate, MA infrastructure, all of these things that kind of are based on in-person care that need to look a little different when you're moving a significant portion of your care model virtually. And it'll be interesting to see how this all shakes out, because we quickly had to stand up, for example, a 18-hour-a-day support center for telehealth, something we had never had previously. And we did that in the course of a few days. It's available to patients and providers who are using telehealth across our system. As we quickly built and deployed a video visit platform to 4,000 physicians, there were a lot of questions. There were a lot of questions from patients and providers alike. And we've done over 100,000 interactions in that support center with patients and providers since putting it up in the middle of March. That didn't exist previously. There's a cost structure to that needs to be supported within the new model of care. And we're going to have to take a hard look at all of our fixed costs for our new care delivery model and right size them on both sides. it speaks to some of the importance of the revenue cycle implications of telehealth and the reimbursement practices that we've been talking about already, and the way that payers are reimbursing things like facility charges related to telehealth. Because while some things go away in a telehealth visit, that is not, there is a lot of infrastructure behind the ability to deliver that video visit that has significant cost to us as a health system, and it has to be represented in the way that we are reimbursed moving forward.
Yeah, so I would like to speak. So I work specifically on physician payment, and it's fee-for-service Medicare. And it's very sort of, it gets to the heart at times of what sort of the limitations of fee-for-service are, because while we are sort of tasked with paying for the resource costs of furnishing a service, a lot of the things that Bill is describing, sort of infrastructure costs, it's very difficult to build that kind of thing into a payment rate for a discrete service under Medicare. So but the way that sort of telehealth reimburses under Medicare is that while it pays the same as if it occurred. So Medicare telehealth, as I said, are all services that would otherwise have occurred in person. So in instances where there's a site of service payment differential between the facility and the non-facility payment rate, Medicare telehealth, outside of the circumstances of the public health emergency, reimburses at the facility payment rate, which is the lesser of the two. What we decided during the pandemic is, because of all of those costs associated with rapidly transitioning from in-person to virtual care, that we felt that we needed to preserve the revenue streams associated with sort of in-person care. And so we decided that rather than reimbursing at the facility payment rate, that we would sort of structure our system such that physicians would get paid sort of the same the same as what they would have gotten paid had the service occurred in person. So in instances where a physician, she normally practices in an office, outside of the PHE, she would sort of bill for that telehealth service, but she would get the facility payment rate, which is triggered by place of service 2. During the pandemic, she would put place of service 11, which is the non-facility payment rate on the claim, and the 95 modifier to identify it as telehealth. And that sort of very, very, very weedy mechanical explanation is sort of our way of getting at sort of acknowledging the infrastructure costs.
Yeah, so I kind of look at this in a couple different ways. One is for the smaller practitioners, and if any of you know any of them, there are still grants available to help them implement telehealth if they have not. And we're willing to help any practice, regardless of whether they're a member or not. One of the things we did at the beginning of the pandemic was my board voted to just help any physician, no matter where they are, with whatever we could. So it's not a big deal. Everything's open. We also have a free, very well-developed billing and coding guideline on our website that explains how to bill and code for everything. Each of the payers are doing things a little differently. So there is some of the basic infrastructure for the smaller practices in place. For the bigger systems, obviously, it's going to be more of a policy discussion. My biggest concern going forward is that I hear proposals where payers are going to pay 30% of a normal visit for telehealth. I've heard that number thrown around a few times now. That is not realistic or fair. It doesn't take into consideration the fixed cost of the service. It is not looking at, there are fixed costs. It doesn't take you any less physicians. You still need to have some type of facility that the physician is going to be in. You still need to be HIPAA compliant. You still have to have an electronic medical record. All those costs need to be considered. Now, does that mean a telehealth visit should be equal to a non-in-person visit? Maybe that's a reasonable argument, but it seems to me that's a concern I have for the infrastructure going forward.
Yeah, I think that's a really good point, Gene. And I think I really appreciate Emily's comments on kind of the way that Medicare has structured this to date. You know, I do think that there needs to be additional dialogue around this. And, you know, the fact is that the video, which is what we all kind of focus on, you know, we focus on the video, is honestly the easy part of telehealth, right? And that E&M service delivery that's happening across the video is surrounded by a lot of infrastructure for making sure patient devices are working and that they are prepared, and that all the same things that happen in person, that we have their medical questionnaires filled out and we understand what they're seeing us for today. And after the fact, the complexity of the kind of revenue cycle management of telehealth is a new kind of addition into, and that the complexity of that, Gene, I haven't seen the guide on your website, but we developed one very similar probably, and it's not a page, right? It's like 25 pages of the complexity of how revenue cycle works around this. So I think we have to acknowledge that two things. One, telehealth isn't right for everything, right? And we have to balance where it is right and where it's not. And the second is figure out how to value it appropriately in a care delivery model that kind of pushes it up into, maybe 20, 30% of the care that we deliver as providers is being virtual. And we have to value it appropriately to make sure that, and this is my fear as somebody that leads telehealth in a big integrated health system, that we go back to the old way because we don't properly do that work. And that is certainly a risk that we face. And I don't think it's the right thing for our patients.
Sounds like there's wonderful opportunity here for new payment models to be introduced. So excited. Hopefully we'll come up with round 2 of this panel, and we'll be able to present some new innovative ideas that have come out of that in terms of funding mechanisms. Emily, you mentioned before there's been quite an uptake of telehealth among Medicare patients, specifically with the telephone-only visits. But can we talk a little bit more about the trends we're seeing in terms of the type of patients that are taking advantage of telehealth services? Are we noticing a difference in demographic factors or coverage type?
Yeah, so in terms of like fee-for-service Medicare broadly, we've seen a really big uptake in utilization for telehealth, obviously since the start of the pandemic. Prior to the pandemic, sort of about 13,000 bennies would get a telehealth service in a week. And in the last week of April, nearly 1.7 million beneficiaries received telehealth services. The dually eligible beneficiaries actually have a higher rate of telehealth use. So 34% of dually eligible beneficiaries have had a telemedicine service, as opposed to just 26% of Medicare only. Amongst the dually eligible population, there are actually not significant differences across racial or ethnic groups or across gender. In terms of zooming back out again to fee-for-service Medicare as a whole, honestly, the most common form of telehealth visit is the office visit, which makes sense. I mean, those visits are the most common across the physician fee schedule. They make up something like just the office outpatient E&Ms are 20 to 25% of overall PFS spending. So it's not surprising that those would also be the most common telehealth visits. But another, and again, this is not surprising, group of services are mental health services. Of bennies who have been receiving mental health services, around 60% of these services have been done by telehealth as during the PHE. And I think too that's going back to the audio only thing. I think that sort of the ability to access these certain counseling and behavioral health services as audio only services have really helped preserve access to what is a vital set of services during the pandemic. And I also think that it points to sort of an interesting area of sort of further kind of consideration for CMS certainly is, how can we use virtual technology to augment and support mental health services outside of the PHE? So I'm just gonna flag that, but yeah, so it's been really astounding actually, the uptake. It's been really interesting.
It's been interesting from our provider perspective too. Pre-COVID, we had telehealth programs that were interacting with, hundreds of patients a day, obviously thousands of patients a day now. And pre-COVID, it skewed female and it skewed younger, and didn't really have any skewing in kind of racial breakup. But post-COVID, it actually has just been universal. It's everybody is using it across all demographics. We did have one really interesting, we did some research as we were rolling out chatbots for COVID symptom checking. And we found that particularly in underserved communities, Black and other underserved minorities interacted with the chatbots with more regularity than they did other telehealth services. And so it's a really interesting point potentially of a low barrier way to try to engage communities that are difficult to engage, and that, you know, in-person care is traditionally very hard to kind of penetrate with into those communities. And so has telehealth been, even during COVID a bit, but pre-COVID certainly. So I think there's more to do there, but the idea of being able to break down barriers for care using digital technologies is a huge opportunity.
We actually have a question from the audience. This is Lauren Rose speaking. You guys game? If you could improve your current telehealth service, what would be the top of your wish list?
That's a tough question. I think we were very quickly faced with that at MedStar Health in March. We had existing telehealth platforms. We quickly realized they would not scale to full enterprise scale when we were faced with the need to do that. We had to build basically a new solution for video visits in a matter of days and roll it out to 4,000 providers, as I mentioned previously. And I know a lot of smaller practices and hospitals faced the same thing. I think as I look at the landscape of technologies available for telehealth, and this is going to sound like a criticism, but I think it's more of a reality of tech investment and venture funding, et cetera. But many of the big players in the space are actually, you know, exceptionally awesome marketing companies with mediocre products. And, you know, I think we quickly found that what we really needed were agile tools that could solve many problems in the kind of video part of telehealth, again, with the full realization that that was just one piece of a much bigger kind of product. You know, EHR embedded video was difficult. You know, it didn't work well. It's not well integrated. It broke a lot. These big vendors were having trouble delivering the technology with reliability that we would expect from, you know, in some cases, billion-dollar companies. And so I really feel like the technology is something we need to focus on that is agile and easy and is almost fades into the background for providers, so that we can focus on the rest of it, which is a lot harder, which is making sure we use it in the right ways and wrap the right workflows around it to make it part of our overall care delivery model.
There are three issues on this one that I would address. And I have worked with, in MedChi, we have a lot of employees, but we worked with a lot of different practices who implemented a lot of different products. There are two things that really concern me. One is a lot of physicians are using non-HIPAA compliant products, and that scares me. I think we could have some really bad things happen. I have doctors who decided just to use FaceTime, or decided, I even had one who was using Facebook Live. I don't know why anybody would, I told them repeatedly, this is such a bad idea, but that scares me that we're gonna have something really bad happen because of the relaxation of HIPAA. It should be a relaxation, not a do whatever you want, and that really worries me. The second thing is a lot of these vendors have gotten doctors to sign contracts, and even I believe some systems have signed contracts where they're getting paid a piece of the volume or the service. That, in my mind, creates a moral hazard and other problems for the physician and or the system down the road, and I don't like that model. We advise people not to enter into those types of agreements around technology. I just think it creates another complexity that's not good. And the third thing that worries me a little bit, and I'm going to tell a personal story on this one. So I swim a lot, and I got swimmer's ear earlier this summer, or at least that's what I thought that I had. And I called my primary care doctor, and he set up a visit for me really quickly. And he's very, obviously we have a good relationship. So he said, you know what, I hate swimmer's ear because 99% of the time it's swimmer's ear, but I can't stick an otoscope in your ear to look at it. And I really like to look at it. So he said, I'll prescribe you the stuff. You know, you swim a lot. You got this 2 summers ago. You know what it's like. But if it's not better, you call me in 3 days. And it wasn't better. I did. I came in and saw him. He goes, well, I was right. You had swimmer's ear, but you also have an inner ear infection. And if I hadn't got that checked, there could have been a really bad outcome. And he went in painstaking detail into that. And his point to me was that telemedicine is wonderful when it works, but it's not a panacea, and it's not the same as the art of medicine. And I'm really afraid particularly with folks younger, and I'm older, but younger generations see everything as being able to be done on a smartphone. The reality of it is there is an art to medicine, and having a nurse or a physician lay their hands on you and look at you for real is very different from having it done. And I'm worried this could result in liability issues or bad outcomes or problems. And those are the three things I'd like to see us change or do differently or fix to kind of answer your question.
Yeah, so in terms of a wish list, so while I'm speaking for CMS, I can't sort of say what sort of Congress should or should not do. But what I can say is that I think that the most impactful changes have been the relaxation of the geographic and site of service restrictions. The fact that beneficiaries did not have to go into a medical facility is huge. Like, having a service from your home can be so important in terms of access to care, in terms of for things like mental health services, stigma. I think that accessibility has been really huge. And then, of course, the geographic restrictions. I mean, there are urban areas that are just as sort of inaccessible to care as the rural areas described in the statute. And so I think that those two pieces have been of everything that we've done in response to COVID from Medicare telehealth perspective. That is the waiver of those two portions of the statute. And the other thing that I would say is that just in general, Medicare telehealth, as it is now, now being outside of the PHE, but is sort of ill-equipped to handle the kind of virtual care as an adjunct to in-person care, and sort of part of a continuum of care that sort of Bill and Jean have both been describing. It's really around sort of services that would otherwise be in person. It doesn't describe things that sort of sit alongside and a complement to in-person services. And while we've tried to sort of, as for physician payment, we've tried to sort of move to services like chronic care management that can encompass a whole, like a big bunch of things. And also, like the virtual check-in, like the remote asynchronous service, which sort of are meant to prevent in-person services. And so we have tried to sort of move the program forward to paying for non-face-to-face or virtual care that can sort of be used to support in-person care. But Medicare telehealth itself is not, it is just fundamentally not built for that task.
Yes, I'll add one thing to what Jean and Emily said. It's really interesting as you think about what does a more telehealth-centric care delivery model mean for each of us, right? Payers, providers, medical societies, and physician groups. There's some inherent risk in that, right? Because when you remove geographic boundaries, it allows for non-traditional players in your geography to deliver services into your geography in certain cases. And we as an integrated health system really deeply believe that connection between provider and patient that transcends an individual encounter is very important, right? And that as you introduce digital technologies into this, we have to make sure that stays maintained and sustained and maybe grown, because we can do more interaction with our patients virtually than we can do in person to follow chronic diseases, as Emily was talking about, and kind of this concept of a more continuous care management kind of approach that includes digital technologies in new and innovative ways. But I think it's important to just call out the fact that there is some risk in this, that, you could imagine from a business opportunity perspective, telehealth allows anybody anywhere theoretically without, any restrictions to deliver care. And it could just become this transaction. And as Jean was describing, my worry is that, younger people in particular may find attractiveness in that until they realize the downsides of it, which is nobody really knows you and your health. And I think that's an important thing to maintain.
Oh, great discussion points. I think, as probably someone in that younger category, using urgent care as a primary care provider just doesn't quite cut it anymore. You reach 30 and all of a sudden you realize you need somebody tracking your health conditions. So definitely agree that's something we're going to have to keep an eye on, especially as we move more services into this virtual environment. So one of our opening poll questions was about what are audiences organizations were concerned about in COVID, across the COVID-19 pandemic, and it was ensuring access to care for members. And then Jean, you spoke about the concern of providers using these non-HIPAA compliant but super accessible, video, audio platforms. Can we talk a little bit about what it means to give patients easy access to technology and sort of the fine line that we walk between having accessible technology and having safe and sustainable technology?
Right, and I guess the first point I'd make, and I make this regularly to physicians who I'm talking to who are figuring out what they're doing or doing something that maybe doesn't make as much sense, is there are a lot of technologies out there that work very well. And I would argue that one of the things we need to do is push for payment of voice calls, because there are a group of population who do not have the money to access a smartphone, possibly, maybe don't have easy access to any type of phone, or maybe don't have a computer in their house. And maybe with them, it's easier for them to make a phone call, and we should be paying for those visits as well to at least get them some kind of level of access. But I do believe that there are plenty of products that work very well. We partner with Dr. First for the Care First grant. It's a Maryland-based company. It's worked very well. A lot of large practices and a lot of small practices in Maryland are using it. There are other products that work very well. DocC is one I've heard positive things about that's HIPAA compliant, and we can rattle them off. So there's really no reason, there's no shortage of these types of technologies that work. The real issue is that sometimes we want to do what's really easy, and we don't think about the consequences until there's a really bad outcome, and that's using the FaceTime Live or whatever, or Facebook Live, I guess it was, or FaceTime. I don't think those are good ideas, and those are things where you're going to end up with problems. And then I think the other issue is that I think the payer community needs to really think about access to care for senior citizens and disadvantaged populations who really might not have access to a smartphone. And those are the things that we need to do. We need to make sure that the payment policy going forward, once we're out of this, matches the access needs. And that's where I think we could have shortcomings and problems.
Yeah, I would echo everything that Jean said. I think it's really important to make sure that HIPAA compliant platforms are used for this. I think there's too much risk moving forward in not using those platforms, and because there are so many available that will work well, it's almost malpractice not to use them at this point, quite honestly, from my perspective. We very quickly realized that ease of use is important both on the patient side and the provider side. Our previous platform we were using for scheduled video visits had a lot of workflow on the provider side that actually replicated in some crazy ways the electronic health record that we all use, Cerner, for our documentation. And so it added way too much time to the provider workflow to go through all of that in order to do a visit with a patient. We also found, and it's something that we've closely tracked during COVID and will publish on likely, that there's a thing that we consider the first pass success rate, meaning a patient wants to see a provider. What percent of the time do they succeed in seeing a provider the first pass, without having to restart the application or click on the link twice or whatever it may be? And that's true on both sides. And pre-COVID, with the technologies we were using, we sometimes had an average first pass success rate in the 70 to 75% range, meaning that 25 to 30% of the time, a patient was going through the frustration of having to do something twice to be able to get into a visit. And that was one of the reasons we quickly pivoted technologies, and we use a different technology than what Jean described. It's called Bluestream Health, which at its core is basically a very simple text message and email-based link generation function that sends those to the patient. They click on it, they consent, and they're immediately in the video visit. And our first pass success rate, going to an easier technology that was really hardened, went up to 90% with changing technologies. And now, again, as I said, that's over 300,000 interactions, and we have over 110,000 patient star ratings of this, and they rate the platform 4.8 out of 5, and the care delivered across it 4.9 out of 5 on average. So really exceptional patient experience across lots of volume.
Yeah, I guess the only thing that I would add, I can't really, so again, physician payment policy, I don't particularly sort of deal with the different kinds of technology or with sort of HIPAA and HIPAA compliance. But I think that, and what I would say is that we are definitely, as an agency, struggling with that line, right, between access to care and ease of access. And I mean, for example, something like the audio only sort of telecommunications technology and the accessibility that that brings with it. And in our proposed rule, we actually have a comment solicitation on this. But at the same time, all of the sort of clinical quality and program integrity concerns that have been alluded to a lot in this conversation, and sort of where is that balance? Like, how do we sort of support technology and all of the flexibilities that it can bring without sort of allowing those flexibilities to completely overwhelm, you know, the other types of concerns that are also really important.
Wonderful. I just want to take a quick second to remind our audience that if you have a question, we would love for you to participate. Please type it into the Q&A box. All of our attendees are in listen only mode, and that's because we're recording the session for ease of use. So you all have spoken about a new care model being developed around telehealth. There's all sorts of other new things happening with the pandemic in terms of how we care for our patients, new safety protocol and procedures, new restrictions on visitors. What has the provider training experience been like from each of your perspectives? You know, not only bringing on this brand new telehealth service line, in some cases brand new, in other cases extremely supplemented, but not only just telehealth, but also thinking about other things that are now required as a result of the pandemic.
Yeah, it's a really interesting question. You know, as we were facing that, right? I think it was a Sunday night at probably midnight. You know, looking at what are we going to do this week to roll out video visits to 4,000 providers. We quickly realized two things. One, we need a platform that's easy to use, that it's just like an iPhone, you pick it up and you can use it for the most part. And then the training becomes kind of nuanced around how it fits into your workflow and less about the technology itself. Again, that led to the selection of the technology that we did roll out to our providers. But it's been a continuous iteration is also something I would point out here, that, you know, while we rolled out one version of that product, you know, that week, and we started doing thousands of visits every day that week, we since have iterated to adding medical assistance into the workflow, and, you know, having additional kind of connect points with patients before the actual visit with the provider. You know, we've tweaked different components of the technology to provide more information to the provider in the visit window, and more information to the patient, the ability to share screens, and all of these different things, adding interpreters in. I mean, we haven't talked about that, but accessibility of telehealth is a hugely important aspect of the sustainability here, and actually adds a lot of advantage over in-person care when it's done right, that you can basically get access to 200 plus languages at the push of a button right within the video or audio session is a huge accessibility advantage, including obviously sign language being very important in that video-based sign language in the video session. So all of those things were kind of iterative, and as we were kind of adding functionality and a little bit of complexity to it, it did all have its own training requirements that came along with it. What I will say is I was stunned by the resilience of providers in COVID. They figured it out. And despite the fact that we were sometimes throwing them half-baked ideas, you know, to help them make sure they could connect with their patients, they figured it out. They were resilient. Their practices were resilient, and the patients got the care they needed, which was what we all wanted to see happen.
Yeah, I would agree with everything Bill just said, but I do want to talk about a couple things that happened during this crisis that kind of, you talked about, you know, different things or things we had to deal with. First of all, I'm really worried about physicians generally and the amount of stress they've been under. A lot of physicians have not had a day off in 120 days, you know, and that is just not a healthy way to live. They're under an increased amount of stress. Those who are in a private practice or in a contract where they're paid on volumes are in trouble. Hospital volumes are down significantly still. Physician volumes are down really low. So that's putting an increased pressure on them economically. Now, we helped a lot of physicians apply for EIDL loans or PPP or other things, but a lot of that is going away. And the advanced payment money, if they took Medicare advanced payment, is going to be due next month. actually in some cases maybe this month, unless there's an extension, which hopefully we'll get. So I would not underestimate all the pressure that the physician and health community is under with regards to these volumes. I'd say the other changes that occurred in the office setting with regards to the clinical, I have to give the Maryland Health Department and Secretary Neal and Howard Haft credit for giving out good advice on a regular basis to the physician community. I also have to give CMS credit. The guidelines are very clear and it can answer most questions. You know, what do you do when you have, and this is a question we answer all the time in MedCai, what happens when one of your workers tests positive with COVID and how do you deal with that and when can they come back? You know, questions about like how do you have to pay your employee if they're positive and they're out because they're being tested or quarantined, and those kind of things that you've had to deal with that you didn't have to deal with before are now all real issues as part of this. I've been very impressed with how the physician community, the healthcare community, the practitioner community has adjusted and changed, but I'm really worried about the economic structure of healthcare. Elective procedures are still way behind and not being done in many cases. Volumes are still way down. I think physicians have adjusted to lighter numbers of people in the office, but again, you're paying for all the fixed costs as if it's fully running. You haven't reduced any of those costs. You still have leases to pay. You still have employees to pay. In most cases, most systems and hospitals, they maybe have done some furloughing or some cutbacks, but really not, most of them have not done that. So those are all real expenses that have occurred. And I think the real pressure are these policy points that need to be adjusted. And how do we deal with that? How do we make sure there's adequate funds to keep the system running? And how do we make sure that the healers are not overburdened and overstressed and having mental health issues?
Yeah, the only thing that I can really add to that is a real sense of acknowledgement of the work that our clinicians have done, and in incredibly challenging circumstances, obviously the pandemic and everything else, it's astounding, but also just in kind of keeping up with the regulations and sort of adjusting to not just the changes of practice that come about from COVID, but all of the sort of rapid fire changes to how sort of services have been paid for during the pandemic. But also, you know, also acknowledging that, as Jean was saying, this is a tremendous burden, and the cost specifically. And I think that CMS is very concerned about how we can sort of continue to support clinicians sort of during and as we begin to come out of this pandemic.
Yeah, I would like to jump on the bandwagon of well-being and burnout is a real issue right now. And, you know, that resilience that I described has an endpoint. And I think providers are feeling more pressure and stress than they probably are letting out into the world. I would also add, we spent a lot of time talking mostly about ambulatory kind of services here, but you know, I think the inpatient environment is also really important and has been impacted heavily by telehealth as well. You know, with the distribution of rare specialties, as I mentioned earlier, but also, I mean, we used our same telehealth platforms to connect patients and families because of visitor restrictions. And I mean, there were just really novel uses of video-based technologies to solve sticky problems, you know, including bringing families into rooms as patients were dying if visitor restrictions kept them out of those environments. So not to end on a kind of sad note, but I think burnout is real, and there's a lot of applications of this still to be found to help solve problems moving forward.
And I think another issue related to that is that I believe there's going to be, and I think we're starting to see an increase in retirements. I've talked to several of the larger hospital systems, and older doctors who maybe were going to hang on for a couple more years just said, look, I'm done, or I'm going to be leaving. And I know a lot of the larger groups have faced this. One of the larger private practice groups in the Montgomery County area had 2 or 3 doctors just decide to go ahead and retire. And that's not to mention the smaller solo practitioners who I think are going to throw the flag up. And that's a problem because we already have a physician shortage. We have a healthcare worker shortage. I mean, anybody who's trained in healthcare is able to find a job instantly. And it just seems that that's another factor that we have to be worried about as we move forward.
Agreed.
What can we do to prepare ourselves for the next pandemic? So not that they come around often, hopefully, but I think that this one took the healthcare industry by storm in a way in this country that we were semi-unprepared in terms of PPE. we had to create some new protocols. And while we had existing remote monitoring and telehealth technology, it hadn't fully been ramped up. So what are some lessons learned that we can begin to apply and sort of keep in reserve for when this may happen again?
I have a running list of a whole bunch of stuff that I'm going to ask for, but I'll give you my top four. Number one, the most important thing that we should have learned, and I'm telling everybody this, we need to make personal protection equipment in America. We should not be relying on foreign countries. This is as big a deal as food and energy. It should be treated as such. It's a national security issue. The idea that we were relying on one of our enemies to provide us PPE is crazy. So that's number one. That should be a national policy initiative. Number two, we should have an economic plan to protect key industries. We should not be in a situation where we're throwing crap together with a series of 4 and 5 major bills. There should be something on the shelf ready to go that we've thought about in a thoughtful way. I think the PPP was brilliant because you kept people employed. I think actually you have to give the government credit for a lot of what they've done, but now we've got a point where they're fighting and nothing's happening and we're getting ready to have a big problem. Really, we should have a plan on that ahead of time. Number three, liability protection. It is ridiculous that we have people who are more worried about being sued than they're worried about getting COVID. The idea that there were some scumbag trial lawyers running ads about ventilators during this crisis in Baltimore Sun and other places is ridiculous. And I just think that there needs to be some type of liability protection. Ironically, in Maryland, we actually had a halfway decent statute that was passed after 9/11. It needs to be tweaked, and it's something we're going to be working on. And my fourth big one is, and this is for you, Emily and Gabby, we got to pay for telehealth going forward for real. So please don't stop. I need you guys to keep paying for it. Let's figure out how to pay for it. And that would be the fourth of my big four that we need to learn from this thing.
Yeah, I would add, I think those are great. Those are actually 4 really good top ones to highlight, Gene. Thank you. Taking it maybe down to a little bit more of a micro level, I think, we have to embrace innovation in our care delivery model a bit more readily than we have previously. And part of that is about continuing to kind of remove or keep barriers to a minimum to that innovation, because I would argue that telehealth has been around a long time, and it was really held back by the barriers that were removed with COVID, and we saw it explode. And we've since proved that, if we had done this 5 years ago, we probably would have been benefiting patients substantially, although certainly the pandemic and the public health emergency has helped drive patient adoption as well. So I think agility and innovation is a key part of this in our care delivery model. I would also argue, as a big integrated health system, it's important to kind of look critically at how we responded, because often we can be glacial in change, and there are good reasons for that. But this is a reminder that we can be agile, as healthcare providers and organizations, and that we can insert new technologies with smart, thoughtful risk-taking into our business strategy and models. But it can only be done by keeping this collegial partnership that I think we all described earlier around the intersection of payer policy, governmental policies at the local and federal and state levels, and provider organizations. And so the conversation has to continue, and we can't let it go back to, in some cases, kind of this loggerheads of different opinions that we can't get past.
Yeah, I mean, I think that I definitely, sort of speaking like as CMS for a minute, sort of definitely hear what you all are saying. I think that we too, I know that we want to continue to have a much more sort of collaborative relationship with our stakeholder community, and have that sort of persist outside of the pandemic. I think that what I would say in sort of a response is that, we really need the help of the provider community. We need the help of the sort of other payers. We need the help of sort of interested stakeholders to help CMS actually determine what what our path forward should be. And I'm going to now plug the physician fee schedule notice of proposed rulemaking. This is where CMS has sort of taken a stab at laying out a vision for the future, where we sort of maintain some certain flexibilities permanently, some temporarily, and some we're not proposing to maintain at all. But we're seeking comment from the public on all of those choices, because we really need additional information. We need people like you to communicate to us sort of what we can best continue sort of, and how we can continue to be, helpful. I mean, and I'm speaking specifically about Medicare telehealth here, but sort of very broadly too, sort of across the agency. And so that's sort of what I would say in response.
No, Emily, thank you for plugging that. I think it's really important that folks on this call, health systems, payers, everybody get involved in kind of looking through that, understanding, and in commenting. There is some great stuff in there, but there are also causes of concern that I think we may want to, as industries, kind of support comment and continued innovation in the physician fee schedule as well. I do think that advocacy is going to be a really important part of this for provider organizations, and we certainly have taken that charge that you speak of, Emily, very seriously, in getting involved in kind of advocacy for where we see important changes needing to be sustained and where we see them potentially not, because I think it can't all stay where it is during the public health emergency. And I think we have to realize that is unrealistic to expect. But we need to find the happy balance that continues to sustain telehealth as an important part of the care delivery model and doesn't support it in places where it is probably not appropriate or lower quality or less safe kind of things.
Great, great discussion. There was a rapid development of some fantastic data tools at the beginning of this pandemic. The state launched a dashboard. Baltimore City specifically launched a very comprehensive dashboard. I know Care First, we built an interactive map that allowed health systems to zoom in on potential pockets of member demographics that would be at risk. Can you talk a little bit about data transparency and management throughout this process and any innovation that has come because of the need to share data more rapidly?
Yeah, it's been a pretty incredible journey for us. We had data as a core kind of principle of how we do business pre-COVID, but we had a whole new world of data that quickly jumped out to us, and we didn't necessarily understand all the linkages. We've already talked about this on this session, but with revenue cycle and workflow and productivity and all of those pieces, and laying in kind of new digital kind of interaction in terms of engagement of patients with links and all of these different things that traditionally had more marketing bents to them, but now are about care delivery and trying to understand how to actually understand those things and that first pass success rate, et cetera. So we quickly stood up a data function that was specifically related to telehealth care delivery, and did a lot of the same types of things that you're describing. I mean, we were looking at from understanding the pandemic in our region, looking at where our visits with COVID-related, complaints in telehealth were coming from, and quickly realized that the hotspots that we were seeing in the ambulatory environment were quickly translating into the next place that our hospital-based resources would be stretched. So really kind of interesting, kind of insights coming out of it, and that led to, in many cases, or in our case, I should say, a very significant shift in focus towards, we call it one MedStar, where every bed is a MedStar bed. And, we kind of broke down the barriers of our facilities and quickly, figured out a way to just move patients effectively between all of them and considering them all as one giant hospital. And that became so important during the pandemic because you could see it geographically. Initial focus was in DC and Montgomery County and PG County. It has since transitioned to our Baltimore hospitals having more COVID positive patients in them, and kind of the ability to kind of manage this as a system. And that includes with other hospitals and other care delivery organizations in those regions as well. So really interesting how data really drove our response and continues to drive our response to this.
One of the things that I think is a big positive for Maryland on the data side was the fact that we have a working and effective HIE. You know, CRISP is incredible. It's and I get to talk to my other colleagues in my other states. A lot of the other states don't have an HIE. The money got wasted and nothing worked, or they have multiple HIEs that fight with each other. I think those guys do a great job. And the thing is, not only is every hospital connected to an HIE, and there was great data in the CRIS system for hospitals on COVID, but also on other things, we have one of the highest levels of ambulatory connectivity. So a lot of physicians who are not connected to a hospital, or maybe have their own practice, or even some who maybe go to multiple systems, have access to things that other people wouldn't have access to. This new data that popped up, like the Care First data and the other data, be nice if we could figure out how to fit that in and maybe have the spirit of collaboration continue and make it even more robust and have access for everybody. That would be something I'd like to see. And the one thing that I'm a little concerned that maybe we haven't done as good a job on, I'm a little worried that the contact tracing hasn't maybe gone as well as it should have. I don't know if this is because the contract, the no bid contract, was given to a Chicago company. I don't know what it is, but I've heard lots of stories from physicians where they, you know, the patient got a call 15 days after, you know, they were tested, and so it was already meaningless. Then the call came from some robo number that said Department of Health, but it came up as potential spam on their cell phone. And so I just am worried that maybe that would have been better to localize some of those services with the health department and with CRISP rather than give it to an outside company. That's my impression, at least. Maybe I'm wrong, maybe I can be corrected, but I've had a lot of concerns, actually, interestingly, more from the hospital-based doctors about and remember, a lot of the COVID treatment is in the hospitals. I think today we had about 450 people in hospitalizations. But I've had a lot of concerns about the whole contact tracing effort and how it's gone here. And that's a place where I think the data has slipped and we can do better. And maybe we could prevent this thing even better if we could figure out how to integrate the contact tracing effort better into our data systems.
Yeah, I don't really have anything additional to add to my co-panelists has said. I think it's a really interesting issue, and it will definitely be sort of important moving forward.
Yeah, we are so fortunate to have CRISP in this state, so we certainly should leverage that relationship and technology. Let's talk a little bit about remote monitoring. Is there a space for remote monitoring in helping to supplement the care that clinicians are providing both virtually and in the office? Could remote monitoring be a key piece of this new clinical care model and perhaps offset some of the burden, either requiring the patient to come in frequently or requiring consistent communication with a member of the clinical staff? Could we utilize remote monitoring to do some of that work?
I can actually start us off since I'm the person who probably has sort of the least to say about it. CMS, Medicare hasn't really been paying for remote monitoring very long. I think that we started paying for it a couple years ago, and then sort of this year we've been paying for it more robustly with more CPT codes as those codes come to us from the AMA. It's an area that is really very interesting to me. It's very sort of it's very rapidly developing. There's a lot of interest, and we definitely hear from the stakeholder community that CMS has not done a great job of being clear in terms of the billing guidance. So I think that it's definitely a place where there's more sort of work for CMS to do.
So I am very excited about remote monitoring. I think this is an incredible opportunity for the physician and healthcare community to really provide a higher level of care and actually lower costs in the long run. Because I think if remote monitoring is used correctly for certain disease states, we can actually keep people out of more expensive settings like emergency rooms. Having said that, I'm also very concerned because everybody and their brother is starting a remote monitoring company in their basement or in their garage, and we are talking to companies who literally have no equipment, have designed an app. I mean, it is amazing what people are saying. So I guess my first point would be very, very careful. MedChi runs a CTO. Actually, we are one of the 2 CTOs in the state of Maryland that actually save CMS money. We're very proud of that. Emeritus and MedCai were the only two who managed to do that. But we run a very successful CTO, and we are working on implementing remote monitoring in a couple spaces. We have a remote monitoring tool for opioid management and pain management that we're very excited about, and we've been piloting with a couple practices. We're going to expand it. The goal there is that we are going to monitor pain reaction, particularly people who are on complex drugs, because there are a lot of hospitalizations and bad outcomes with that. And if we can present that at a lower, if we can improve that, it could lower costs. We've been looking for one that's more traditional, you know, in that diabetes space, primary care space. We've had trouble with that. A lot of the companies we've dealt with don't have the equipment, aren't really ready, have not worked with any doctors yet. We haven't felt comfortable. We're talking to a lot of people. We will do that, but we're being cautious and judicious before we implement it. And the third area where I think there's a lot of opportunity, and again, we've been speaking actually with a company from Hopkins that seems interesting, is heart failure, and that's a little differently. Emily can explain this better than I can, but the codes related to heart remote monitoring for heart failure are actually technically not remote monitoring, I think, but anyway, nonetheless, we see that as part of this whole space. So I'm excited. I think this is a great opportunity. My only caution would be is take your time, move slowly, start with the pilot, see how it goes, see how the billing goes. Don't get yourself in trouble with this or get yourself into a mess. I think you're going to have a lot of these companies merge together, combine, disappear, go out of business. So getting the right folks is key as far as partners on the technology side, because it really is so new.
Yeah, there's a super important point in all of that, Gene. Thank you. Of crawl, walk, run with this one, and you know we as a provider would completely agree with that, and that's both because you know certainly there are pitfalls in the technologies. I would completely agree with your statement that there's a lot of mom and pops out there in remote monitoring. We've done a pretty exhaustive landscape of them ourselves, and you know I wanted to start though by saying, there's a place for remote monitoring in COVID and the public health emergency as well, and we certainly and many other providers have used it for symptom monitoring and you know kind of patient self-reported kind of monitoring, either without connection to a provider or with connection to a provider. So self-monitoring or active monitoring would be two ways to look at that, and we've rolled that out to thousands of patients and found it to be a very successful way of kind of keeping a light touch with people that we have either a modicum of worry about or they have a modicum of worry about themselves, and we've kept them out of care environments that are busy, you know, urgent care centers, EDs, or primary care physician offices. So even though they haven't all been busy during the public health emergency, as you all know. So I think there's an interesting COVID application, but taking it beyond that, there are real applications, as Gene described, around chronic disease management. And honestly, it's across the gamut. I mean, it goes from behavioral health, where it's not really about physiologic monitoring. It's actually much more about, you know, kind of behavioral monitoring, to physiologic monitoring and heart failure and hypertension and diabetes and all of these chronic disease states. But there's also really important applications of remote monitoring in transitions, post-acute care transitions being probably the one that we think the most about. But you know, patients coming out of the acute care setting who need to be followed and make sure that they're actually okay as they're being pushed back out into the community, whether it's into their homes or transition sites, et cetera. So really good application there as well. And I think as you look at the opportunity for us as a provider and how we look at this, there's two distinct value propositions. There's decreasing the total cost of care, you know, where patients are at risk, or in alternative payment models with our payer partners. And then there is the fee-for-service opportunity that was described by Emily and Gene, that I think is one that we have to be really thoughtful about applying. And a little bit of a plug here, there's actually a bit of a landmine in the physician fee schedule where CMS has clarified that the 20 minutes for remote monitoring actually has to be communication with the patient, meaning on the phone. It's not about indirect kind of monitoring of their physiologic, et cetera. That's a really big change for people that are interested in fee-for-service, you know, kind of reimbursement for remote monitoring. And we should all be commenting on that to make sure that it aligns with the way that we see the value aligning. Because to me, the value is not only about the actual conversation with the patient, it's about somebody having eyes on the physiologic or behavioral data of that patient in an ongoing way in order to interact with the patient if required. But we don't want to bother the patient as part of this if their data is looking positive and good. So lots of opportunity in remote monitoring. We are certainly diving into it at significant scale, both in the fee-for-service space and in the total cost of care reduction space across all of those domains that I described.
Yes, please comment in response to the PFS. I mean, that is such a great example of the kind of information that we need from the public. So absolutely.
What else can our audience members do to get involved, to participate in recovery from the pandemic, maintaining innovation as a result of the pandemic, key policy changes? You know, we spoke about this being really a local thing that we're all collaborating together to solve. And so what else can our audience members do?
So besides commenting on the physician fee schedule, comment period closes August 5th. I mean, I think that just continuing to engage with CMS, you know, even outside of that. Also, though many of the flexibilities have to sort of, those like changes need to be, if they need to be made permanent, that's a congressional move. So sort of to the extent to which folks think that certain portions of the statute should be changed or removed or whatever, that information needs to be conveyed to Congress.
Yeah, I want to also make a pitch, and I agree with everything Emily just said. It's very important to be focused on the federal level, but let's not underestimate the importance of the state level as well. As you know, the state of Maryland proposed a 4% reduction in Medicaid rates for physician practices. That is a nightmare, not only for my physicians, but also for the systems who rely on that money. And those patients are some of the most complex patients. Fortunately, that was put on hold till January 1, but it's scheduled to occur on January 1. So right now, the state of Maryland is saying that a Medicaid participant is worth, with this rule, would be worth about 89% of what a Medicare participant is. And where I'm from, we should treat our poor people the same as we do our wealthier people. And it makes no sense to me that one of my neighbors who lives in a big house on the water on the Eastern Shore, who happens to be on Medicare, gets a higher level of service than a poor person who lives in Capitol Heights. And that's what the state of Maryland is saying. And I think that's an important issue going forward. I also think we need to go and talk to the state about additional liability protections around COVID. I'm expecting there will be a flood of lawsuits around this issue, and it's ridiculous. We're in a public emergency. We're all behaving in a way to protect people and make sure they're safe, and that should be taken into consideration. I just think we need to be engaged. One of the problems, one of the risks is we're all so busy just trying to take care of people, trying to keep our businesses running, trying to keep everything happening that needs to happen so people get the care they need, that we don't talk to the policymakers, and the people who have the time to do it do, and then we're put at a big disadvantage. So that would be my pitch. That don't forget to take the time to pay attention. Look at that HFAM alert. Look at the MedCai alert. Look at the alert from your hospital system. See what University of Maryland or University of or MedStar, or LifeBridge, or Hopkins is sending out, and follow up and talk to people and let them know that these policies matter and make a difference. Do not underestimate the pressure that state government is going to be under financially because of this crisis. They're losing billions of dollars in tax revenue, and they're going to have to cut things. And that's not good for us when healthcare is a very large part of the budget.
Yeah, those are great points, Gene and Emily. I would add maybe a little bit more practical, kind of hope going forward that, telehealth for years, particularly in the provider space, has kind of been like a bunch of geeks working in a closet at small kind of pilot scale, right, across everything that we're talking about. And suddenly it's mainstream. And I think that presents an opportunity for us to share, whether it's through research or just best practice sharing, some of the lessons that we've learned over the last 5 or 6 months in order to make all of us better in a community of practice related to telehealth as a significant part of the care delivery model going forward. And I think that includes all the phases of telehealth that we've talked about on this. It's not just about the quality and safety and the care delivery. It's about the revenue cycle implications and sharing best practices related to that. And it's about the alternative payment models that are showing success in the payer space in partnership with provider organizations. I really think that we need to maintain our momentum through continuing to kind of focus on that collegiality and a community of practice about this, that maybe remove some of the competitiveness that is inherent in kind of what we do in our interactions at times. But I do believe this is the right thing for our patients, and we need to figure out together how to best utilize it.
Great. Well, on behalf of HFMA, I want to thank all of our panelists, Bill, Jean, Emily. Thank you so much for volunteering your time this afternoon. It was a fabulous discussion, and I hope our audience enjoyed it as much as I did. I'm going to go ahead and give just a few quick announcements while we wrap up. I want to put in a plug for a couple more HFMA events that are upcoming. We have a webinar on insurance strategy during challenging times. That's going to be Thursday, August 27th from 12 to 1. Information will be available on the HFMA Maryland website. We also have a physician practice panel, tips and strategies for recovering from COVID. So a lot of great tips were given this afternoon, but if this one is specifically for physician groups, and that's going to be Friday, September 18th from 12 to 1. And then finally, we have our annual fall conference. We're really sad to not be in person all together this fall, but we will be doing a virtual fall conference, and that will start on Wednesday, September 30th. So with that, I'm going to allow Kalita to launch the last and final poll. So a reminder, if you're using this for CPEs, please go ahead and say that you've attended so we can capture your attendance and send you that CPE form.
We'll give another 15 seconds.
Okay, we got 100% yes this time. That's great. Wonderful. Thank you all again so much. And another huge thanks to our sponsors who are on the screen. We couldn't do the wonderful education without them. And I continue all to tune in for some more great educational events this year. We're going to be offering them free of charge because we understand we have to be virtual, but we promise they're going to be packed with lots of great content, just like this afternoon was. So again, thank you so much to our panelists. And on behalf of HFMA, thank you so much for joining us. Have a great afternoon.
Thanks. That was good.